Hi everyone, welcome to another Monty Heart lecture. Today we have Dr. Virend Somers who will be speaking about sleep apnea and cardiovascular disease, what the cardiologists need to know. It's a real pleasure to have Dr. Somers today here, who is a world expert on sleep and cardiovascular disease. He is a consultant cardiologist in the Department of Cardiovascular Diseases at Mayo Clinic in Rochester and a Mayo Foundation clinical investigator. Dr. Somers also directs the cardiovascular facility and the sleep facility within the Center for Clinical and Translational Science, and he holds the academic rank of Professor of Medicine at Mayo Clinic College of Medicine. Dr. Somers earned his medical degree at the University of Natal in South Africa and then completed internships at the University of Natal and King Edward Hospital. Afterwards, he went to Oxford where he obtained a doctor in philosophy degree and then moved to the US and did a postdoc fellowship residency in internal medicine and fellowship in cardiovascular diseases at the University of Iowa. Dr. Sommer's translational research program focuses on the role of autonomic nervous system in cardiovascular regulation with an emphasis on normal and disordered sleep. He holds many honors and awards, including the Mayo Distinguished Investigator Award, the Mayo Department of Medicine Outstanding Investigator Award, University of Iowa Distinguished Cardiovascular Scientist, South African Society of Sleep Medicine Lifetime Achievement Award, and many others. He has an age index of 111 and over 60,000 citations. So it's a real pleasure to have you here today. Thank you so much for taking the time.
Yeah, thanks, Leandro, for that very nice introduction, and for the opportunity to talk here this morning. Um, I'm going to talk about sleep and cardiovascular disease, and really try and focus on what the cardiologist needs to know. There's a lot that's going on in sleep apnea, a lot of different aspects and consequences, but I'd like to just give a kind of drill down to what the practicing cardiologist needs in approaching these patients who have cardiovascular disease and also comorbid sleep apnea. My slide's not moving, I wonder. Let's see. Okay, these are my disclosures, and I'll let you look at them very quickly. Um, So the learning objectives for today are first to look at the differences between central and obstructive sleep apnea. By the way, can you see my pointer?
Yes, we can.
You can, brilliant. So differences between central and obstructive sleep apnea, then look at the cardiovascular pathophysiology of sleep apnea. What happens during sleep apnea that makes it potentially bad for the cardiology patient? Then of the many patients that we see with cardiovascular disease and sleep apnea, how do we know who is at high risk, who needs intervention, and then look at the types of intervention, look at the benefits and risks of positive airway pressure in both central and obstructive sleep apnea, and last, what are the alternative treatment options? I know many people in the audience probably are very happy with CPAP and some are less happy. So what are the alternatives, and what's the evidence that those alternatives may be beneficial? So we'll start by giving a shout out to the American Heart Association, which recently took its life's simple sevens, which were these seven characteristics in black, and added sleep to it. That healthy sleep was actually very important for cardiovascular health and actually also important for glucose modulation, for weight, lipids, blood pressure. And so they made it life's essential eight. And so it's good that they recognize the importance of sleep. And it wasn't just sleep apnea, it was healthy sleep overall, because it's not just not breathing during sleep that's a problem. It's how long you sleep, how well you sleep. But we won't get into that today. Today we'll focus only on sleep apnea. Now, sleep disordered breathing, really two major types: obstructive sleep apnea and central sleep apnea. Obstructive sleep apnea is a kind of apnea that's famous. It's the one that's associated with severe obesity, with disruptive snoring, with people having severe daytime somnolence, and that sleep apnea occurs because, not because you're not breathing. The patients are trying to breathe, very, very desperately trying to breathe. But because the upper airway becomes lax during REM sleep or rapid eye movement sleep, and I'll talk more about that later, because of that, the airway is more amenable to collapse during inspiration. And that creates the obstruction, either partial or complete, and that we know as obstructive sleep apnea. Central sleep apnea, on the other hand, is kind of apnea that usually occurs from a cardiologist perspective in patients with heart failure, also occurs in premature infants, occurs in people at altitude because of the low carbon dioxide they generate because of hyperventilation that creates a central sleep apnea periodic breathing pattern. Now, in terms of treatment, I'm going to focus very briefly on central sleep apnea because I'd like to spend most of the time on obstructive apnea, but there's a couple of things about central sleep apnea that are important to know. The first is the study that I was involved in, and it at the time was the largest randomized controlled trial of treating sleep apnea. And we focused only on central sleep apnea. It was a multinational, multi-center study. And we were pretty sure that the treatment, which very nicely decreased the severity of the sleep apnea, was going to result in a significant mortality benefit. It turned out, I'm not sure, is this, maybe if I shrink that, yeah, that's better. It turned out that the results were stunning, to say the least. The primary endpoint was neutral. This is using adaptive servoventilation. That's a kind of positive airway pressure that where the machine will breathe. It'll sense that you're not breathing as required, and then chip in and breathe for you. So it's an adaptive servoventilation system, and it's fairly effective at fixing the central sleep apnea. But the primary endpoint, while it was neutral, the primary endpoint being time to first event of all-cause death, life-saving cardiovascular intervention, unplanned hospitalization for heart failure, there was a slight trend towards worsened outcomes with ASV. Now, when we looked at cardiovascular mortality, that actually was significantly increased with ASV. Hazard ratio of 1.34, one-third relative risk increase in people given the adaptive servoventilation. So this was a surprise. And then the question became, was this a class effect, meaning that any ASV, adaptive servo treatment, was going to increase mortality, or was this purely because of the algorithm in the ResMed machine that we used? And each machine has its own algorithm, and the algorithms can have a very significant effect on hemodynamics and breathing patterns. And so Douglas Bradley in Toronto had at the time been conducting the Advent study, which is a similar study looking at ASV treatment of central sleep apnea and heart failure with a reduced ejection fraction. And this was a composite outcome, all-cause mortality, first hospital admission, AFib, ICD shock. Now, very fortunately, what Doug found was that when you used a different ASV device, using a different algorithm, what he found was this is the ASV in red. There was actually no increased mortality or no increased events with ASV. And in fact, if anything, there was a slight decrease in the hazard ratio, not significant, of course, but it showed that this was probably not a class effect from adaptive servoventilation, but primarily the effect of probably the algorithm that was used in the machine that we used. Of course, his numbers were a lot smaller than we had, but still the signal wasn't at all troublesome. And so at this point, I think the best approach to people with systolic dysfunction, heart failure, HFrEF, is and a Cheyne-Stokes or central sleep apnea. First, treat the heart failure, and second, you could potentially use ASV, but primarily to improve sleep quality, not to improve cardiovascular outcomes. So we'll leave central sleep apnea at that point and talk now about obstructive sleep apnea. This is very nicely covered in a scientific statement from about 4 years ago. We try and do one of these every 10 to 15 years just to update the field, mainly because it's moving very quickly. And in this particular iteration of the obstructive sleep apnea cardiovascular disease relationship, the key things that were new was the advent of home sleep testing. Now, before we started, this is for the audience, Leandro and I were talking about the fact that it's very hard to get a sleep study done. And so the sleep community recognized that and got home sleep testing approved. So now you can give a patient a device, they take it home, and they don't have to come into the hospital, which is much more expensive, much more logistically challenging. They can do multiple tests at home. And so the home sleep testing is a huge advance and has greatly increased the numbers of people being treated. Another feature of the scientific statement was disparities in diagnosis, in treatment, and in outcomes, and also the recognition that comorbidity does not imply causality. I'll talk more about that later. What this means is that just because sleep apnea is comorbid with a disease, and we think that sleep apnea causes that disease in that particular patient, that may not be the case. Like a hypertensive patient, hypertension is multifactorial. Just because someone has sleep apnea and hypertension, both diseases are common. It could be a casual comorbidity, but treating the sleep apnea may not necessarily lower the blood pressure because there are other things raising the blood pressure. And we'll talk about that further. And then also the identification of high-risk subgroups who may be most responsive to therapy. Those who are sleepy, those who have a greater hypoxemic burden during the night. Now, how do we know someone has obstructive sleep apnea? Signs and symptoms very quickly, often very sleepy in the daytime. They have morning headaches, some memory impairment, irritability, difficulty concentrating, nocturia. Nocturia is a sign of sleep apnea. Decreased libido and erectile dysfunction. Always consider sleep apnea in these patients because testosterone is produced at night. If your sleep is disturbed at night, there's a concern that that may affect your testosterone production. What do you find on exam? They're often, but not always, obese. Neck is usually thicker. Craniofacial abnormalities, and a Mullen-Patty score of 3 or more. Now, what's the Mullen-Patty score? That's when you look into the mouth and you look at the soft palate. If you can see the soft palate completely, that's class 1. Nothing to worry about. Class 2 is a complete visualization of the uvula. And class 3 is you see only the base of the uvula. That's the base of the uvula there. And class 4 is you just don't see the soft palate at all. So those are 3 and 4 are the Mullen-Patty scores to really concern yourself with. And I urge everybody when you think someone may have sleep apnea, look in the throat and get an idea of how much space there is between the tongue and the soft palate. So from a cardiovascular point of view, why should we worry about sleep apnea? Well, during sleep apnea, we had hypoxemia and reoxygenation, autonomic dysfunction, which I'll show you, arousals with sleep disruption, intrathoracic pressure changes, -40 pressure, negative pressure in the chest, which affects the atrium and the other chambers of the heart, affects the aorta, hypercapnia. All of these together give you inflammation, atherosclerosis, endothelial dysfunction, increased coagulability. You have metabolic dysregulation, hemodynamic changes, which I'll show you, left atrial enlargement because of this negative pressure constantly in the chest, and then sympathetic activation, which I'll also show you. And that has consequences for, bread and butter cardiovascular problems, high blood pressure, AFib, heart failure, coronary artery disease, stroke, somewhat to pulmonary hypertension, not terribly important except in people with obesity, hypoventilation syndrome, certainly relevant to metabolic syndrome, diabetes, and very relevant to increased mortality. Now, what's the prevalence of sleep apnea in heart diseases generally? Well, 1/3 of coronary artery disease, about half of your AFib patients, about 3/4 of your heart failure, And probably around 80% of people with resistant hypertension will likely have obstructive sleep apnea, comorbid. Now remember, just because the sleep apnea is comorbid doesn't mean it's causing these things. It's there, and it may be causing in some people. And the key is to find out which disease condition in your patient is potentially being caused by the sleep apnea, and therefore the sleep apnea treatment is going to potentially help make the disease better. We'll talk about that as we go along. Now, hypertension. Patients with sleep apnea have a high prevalence of hypertension. Patients with hypertension have a high prevalence of sleep apnea. And so why is that? To understand it, we have to think about what's happening during sleep. Now, this is normal sleep. This is not an apnea. These are healthy young people, and this shows sympathetic activity recorded from a peroneal nerve in the leg. So you stick a needle in the peroneal nerve, you find the sympathetic nerve fascicles. So you can record moment by moment, real time measures of the vasoconstrictor signal going from the brain to the peripheral blood vessels, kind of tapping into a phone line. You're tapping into the sympathetic nervous system. And the magnitude of sympathetic activity is shown by the number of spikes, these spikes, and the height of the spikes. So when you're awake, this is kind of a healthy level of sympathetic activity. This is your beat by beat blood pressure. And you go into stage 2, stage 3. Stage 4 is deep sleep. Okay, what we call N3 nowadays. In those days, we call stage 4. And when you're in deep sleep, you have very low sympathetic activity, your blood pressure is lower, and your heart rate is slower. Then when you start dreaming, when you're in REM, which is a time when dreams often occur, and you get rapid eye movements that are apparent from the oculogram, and even you'll see it with your naked eye. You see sympathetic activity goes up to very high levels. It's very irregular, very high, and blood pressure and heart rate are labile, spike, and they go down. Heart rate slows, increases. You get vagal bursts, sympathetic bursts. You can get Wenckebach. You can even get complete heart block with even sinus pauses of up to 10 seconds, just from a healthy subject during REM sleep. So this is what happens in healthy sleep. Now, what happens in someone with sleep apnea? So it's completely different. This is a healthy, otherwise healthy, newly diagnosed, never treated obstructive apnea patient. This is a sympathetic activity when he's wide awake, he's anoxic, he's breathing normally, intra-arterial blood pressure is 130/60. So he goes to sleep. He's in REM sleep or dream sleep. Now, in REM, you tend to lose your postural muscle tone. You also lose some tone in the upper airway. The tongue more easily falls backwards into the airway, more easily obstructed. So you get obstructive sleep apnea, and the hypoxemia and the hypercapnia during your apneic episode increases or stimulates the peripheral and central chemoreceptors, causing this high level of sympathetic drive. And that sympathetic drive gets greater as your hypoxia and hypercapnia get worse. That's your obstructive apnea. And you see that the vasoconstriction from there results in a blood pressure that gets up to about 230 over or 130. And this is from a normotensive blood pressure when he was awake. And remember, this is intra-arterial. So this is the real, honest to goodness blood pressure that you're seeing. Now, other things happen, including this bradycardia, which is very interesting. But that requires a whole different talk to talk about basically the diving reflex, and sometimes can manifest as severe bradyarrhythmias. And then you treat them with CPAP, and sympathetic activity is better, blood pressure is lower, and breathing is more regular. So this is one of the reasons we think why hypertension occurs in the apneic patients, because this constant night after night, apnea after apnea, increase in blood pressure resets the barrel reflex, increases your overall sympathetic activity, so it's high even during the daytime, and that raises your daytime blood pressure levels. Now, what happens is lots of data on hypertension, but I just want to focus for reasons of time on resistant hypertension. What are the data on CPAP treatment of obstructive apneic patients who also have resistant hypertension? These are randomized controlled trials on the left, and there's 5 different studies. The systolic blood pressure is shown in blue. diastolic blood pressure in red. Now, these are only 24-hour blood pressures, so they're really the gold standard blood pressure measure. And the net reduction of blood pressure in these resistant hypertensive patients varied from about very little, less than 1, to as much as about 9. And the reason for this variation in systolic response and diastolic responses is again because these are resistant hypertensive patients. They have sleep apnea. In many of these patients, sleep apnea is causing the resistant hypertension. In many of them, it isn't. And so in some, there'll be a great treatment response. In others, it'll be less impressive. And this is a mix of them all, because at this point, it's hard to tell who is going to be a responder and who is not. But overall, in meta-analyses, you can see that there's a 4 to 5 millimeter of mercury reduction in systolic and diastolic blood pressures with CPAP treatment of resistant hypertension. Okay, let's see. So in summary, both sleep apnea and hypertension are common and therefore comorbid. Hypertension may not necessarily be secondary to the sleep apnea. Hence, treatment of sleep apnea may not necessarily lower the blood pressure. CPAP therapy effects are inconsistent, and meta-analyses overall 4 to 7 millimeters of mercury reduction in resistant hypertensives. And what happens in regular hypertension with CPAP and with other treatments like oral appliances? Well, again, meta-analyses say your blood pressure, if you're a regular common or garden hypertensive with apnea, you treat the apnea, your blood pressure will fall by about 2 to 3 millimeters of mercury. Now, how do you know? What are the clues as to saying which patient is going to respond to your treatment and which one isn't? Here, the predictors of blood pressure response are really the presence of severe hypertension resistant, how low the oxygen falls at night, and daytime sleepiness. Also, young age. Young age, daytime sleepiness, uncontrolled blood pressure, a low oxygen at night, and a very high AHI with daytime sleepiness, Epworth sleepiness score of more than 10, and CPAP adherence. The more adherent you are to CPAP, the more likely you are to see a blood pressure fall with CPAP therapy. So now let's talk about myocardial infarction, daytime sleepiness, and sudden cardiac death. We saw some daytime sleepiness with the hypertension section. How does that translate to the more definitive cardiovascular outcomes like heart attacks and sudden death? First, we'll look at what was the Sleep Heart Health Study. And this was a study, a community study, where they did sleep studies in everybody, regardless of your symptoms. And they looked at all the different outcomes, hypertension outcome, new or instant cardiovascular disease outcome, and tried to link that to the presence of sleep apnea. What was clear from that study was if you had hypertension and it was untreated for 4 years, you had a 3-fold greater risk of developing new onset incident hypertension. Now, here we see new or instant CVD, and AHI wasn't a very good predictor. The apnea-hypopnea index, which is a standard metric we use to quantify obstructive sleep apnea, wasn't a good predictor. What was a good predictor was how sleepy patients were. This is excessively sleepy, which is the red, and disturbed sleep but not sleepy or minimally symptomatic were green and blue. And what was clear was that if you're excessively sleepy, you had a lower survival probability free of incident cardiovascular disease. And here's a more clear representation of how excessive sleepiness gives you a 1.75-fold increase in hazard ratio of new CVD, whereas the others really did not. So this is the high risk group, sleep apneics who are excessively sleepy. Now let's talk about myocardial infarction. This is a study that Farima Assert did with us when she was a fellow. She's now a very senior person in ResMed, doing very well. What she did was she looked at all our myocardial infarction patients coming to St. Mary's Hospital, all of those who'd never had a sleep study before. The other thing was she also made sure that in everybody, chest pain was the sentinel symptom of the MI. And the reason we wanted that was because then we could very clearly say what time the heart attack occurred. So if you have chest pain, you knew it happened at 3 in the morning, I woke up, or happened at 4 in the afternoon. So we had a good marker of when the heart attack occurred. And what Farima did was bring in all of these patients where we did not know their sleep apnea status. They'd never had a study. And they were admitted for a heart attack. And then she did sleep studies on them and looked to see how the timing of the heart attack was related to whether or not they had sleep apnea. So first, the blues are the people who didn't have sleep apnea. And you can see that most of them had their heart attacks when we'd expect in the morning, 6 to about 2. And very few, less than, about 15% had their heart attacks at night between 10 p.m. and 6 a.m. When they were most likely to be asleep. But when you look at people who were found to have newly diagnosed sleep apnea, their heart attacks occurred primarily, or the plurality of the heart attacks were at night between 10 and 6 a.m. So if your patient has a heart attack, wakes them from sleep, you probably want to look for obstructive sleep apnea because that seems to be closely associated. Now, we took these patients. Now, it turns out actually, which is interesting, is that people with cardiovascular disease like myocardial infarctions, they don't really rush into getting treatment for their sleep apnea. And all of the patients that we saw got letters from us. They were advised, you listen, you've got sleep apnea, it's bad for your heart. You really ought to go and see a doctor and let them know, or see a sleep specialist. But really, very few of them actually ended up getting treatment because they didn't want treatment or never went to the sleep clinic. And so we followed them up for about 4 years. And we divided them into people with what we call moderate to severe sleep apnea, AHI of more than 15 in the orange, but also with daytime somnolence with EDS. And then the blue group are people with the same moderate to severe sleep apnea, AHI more than 15, but no sleepiness. And the last group are people who didn't have sleep apnea at all, uh, less than 5. These are normal people, had a heart attack, but they don't have sleep apnea. What I want you to look at is by 3 years, 36 months after their heart attack, even though these people had moderate sleep apnea by the AHI, they were not sleepy. And their likelihood of MACE was really not much different compared to people without any sleep apnea. Now, if you took this group and put them into a randomized controlled trial of CPAP and no CPAP, you're really not going to see much effect by 3 years because there isn't a high risk of MACE at 3 years. But look at the sleepy group. This is a similar AHI, but they have excessive daytime somnolence. They have a 60 to 70% increased risk of MACE or risk of MACE. And so this is the group, this very sleepy group, who needs to be in the randomized controlled trials, but they're not. They left out. If you're very sleepy and you got sleep apnea, they don't put you in the randomized controlled trials because there's this ethical dilemma that you're going to have a motor vehicle accident, and we randomize you to not being treated. And so that's the problem. And we'll talk more about that in the next couple of slides. So, heart attacks, if you have sleep apnea, they are more likely to occur during the nighttime. What about sudden death? In this study, Apur Gami, who's now an electrophysiologist in Chicago, when he was in our lab, took all adult Minnesota residents who had diagnostic sleep studies, and there's many of them, also had sudden cardiac death. And we also knew the timing of that sudden death episode. And he looked to see how the presence of known sleep apnea or known no sleep apnea, because they'd had a sleep study, affected the timing of the sudden death episode. And this is what he found, that if you didn't have sleep apnea in blue, 24% likelihood of having a sudden death episode between 10 p.m. and 6 a.m. Again, plurality would occur after 6 a.m. to 2 p.m. But if you had sleep apnea, more than half of the sudden death episodes, the majority, would actually occur during the nighttime hours, between 10 p.m. and 6 a.m. So here's evidence that sleep apnea can or is associated with an increased nocturnal risk of myocardial infarction from the first study and now sudden death from the second study. And it may be arrhythmias that's causing some of the sudden death, not just an MI, because these are data from Zaid and Shwiri, where they looked at people who had ICDs and looked at people with and without sleep apnea. 45 of them, 26 had sleep disordered breathing. And what they did was divide them into people who didn't have sleep apnea, AHI less than 10 in the left two panels, and with sleep apnea, AHI more than 10 in the right two panels. And when you look at the timing of death or of the arrhythmic event, the appropriate shock, um, what you see is that if you didn't have sleep apnea, this group, there really was no difference in whether the event occurred between midnight and 6 a.m. or 6 a.m. and midnight. But if you had sleep apnea, you were much more likely to develop an arrhythmic event between midnight and 6 a.m. than between 6 a.m. and midnight. So again, corroborating the data I'd shown you earlier, that in patients with sleep apnea, sudden death risk is potentially greater at night. And so if your patient, I've got a number of these, if your patient has a appropriate ICD shock at night that wakes them from sleep, you may want to look for obstructive sleep apnea. So last, let's look at, we looked at central sleep apnea, effects of treatment, then we talked about obstructive sleep apnea, what it is, and why it's bad for the heart, and we looked at high blood pressure and the sympathetic activation that potentially leads to some of the hypertension. We looked at heart attacks and sudden death occurring at night, and the role of daytime sleepiness as a prognostic marker. Now, what about the effects of sleep apnea treatment on cardiovascular outcomes? I'll start with a SAVE study. This was another very surprising and disappointing study for the sleep community because they randomized about 2,700 people to either CPAP or usual care. All of them had cardiovascular disease, and all of them had sleep apnea, and there really was no difference between CPAP and usual care. Now, so therapy with CPAP plus usual care as compared to usual care alone did not prevent cardiovascular events. However, CPAP reduced anxiety, depression, days away from work, and improved physical and mental quality of life. Patients who were more adherent to CPAP therapy had a lower risk of stroke than in the usual care group. The other problems with SAVE was, as we talked multiple times, OSA may be comorbid, but not always causal. Suboptimal CPAP adherence. People use CPAP for about generally 3.5 hours. Some use it for more than 4, and those showed benefit in terms of cerebrovascular events. They didn't study sleepy people. They didn't study people with what we call an Epworth sleepiness score of more than 15. So these were not the high-risk sleepy group. So straight away, they're taking a low-risk group and randomizing them to treatment, and maybe won't see a benefit of treatment. The other thing is that another sign of high risk is how low your oxygen falls at night. And they excluded people whose oxygen fell to below 80% for more than 10% of the night. So those are the more severe hypoxemia at high risk were left out. So when you take a low risk group and then you randomize them to treatment or no treatment, the treatment is only partly used, it's going to be hard to find an effect in only 3 or 4 years or 5 years. So that's something to keep in mind. That we need alternatives. Instead of using the AHI to say how bad sleep apnea is, we should use maybe alternative metrics, maybe hypoxic burden, nighttime sleep quality, autonomic responses to arousals. We need alternative treatments that are more effective and sustained throughout the night, and we'll look at some of those. And then we have to keep in mind that we're talking about primary versus secondary prevention. We need to recognize that maybe treating sleep apnea doesn't in fact reduce cardiovascular events because the pathophysiologic processes at a cellular level, once they're activated, are not readily reversible. So that's also a consideration that we have to bear in mind. Now, I'm showing you this slide. This is when you order oximetry in your patients. This is what comes out of it. This is the oxygen saturation. And I'm showing this slide for a couple of reasons. One is this patient had an AHI of 24 per hour, which is okay, it's bad, but it's not horrible. But when you look at the desaturation, that's really bad. Like he gets down to very low levels. So we got down to 83% here. Now, what does 83% mean? You hold your breath till you think you're dying. Maybe your O2 sat, if you're an athlete, will fall to 92%. To get down to 83% is really, 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 really difficult. You need to be a trained extreme diver to even get down to those levels. But these sleep apneics do that frequently, and they do it every night, multiple times during the night. The other thing is that, so remember the AHI as a metric, because you divide over the entire time of sleep, there are much of sleep where you're not in REM, where you don't have apnea. It kind of can underestimate the severity of the apnea. The other thing is that you see the hypoxemia, sleep apnea occurs in clusters, often when you're in REM, and the hypoxemia is worst during the later parts of sleep. Now, if you only use CPAP for 3 or 4 hours a night, you're using it here, and then you stop, and then the worst part of the apnea is completely unaddressed. So this is a problem with a treatment that's only used for part of the night, particularly if it's only used for the first half of the night. So those are two things that I want you to know from this slide. Well, three. This is what oximetry looks like. Many people will get the result, but not look at the actual trace. Here's another problem with CPAP withdrawal. So here's a patient who was on CPAP, doing very well, breathing normally, and sympathetic activity is not that bad. So it was the middle of the night. I turned his CPAP down by about 2 centimeters of water, and bam, he got a bad apnea. Look at the sympathetic response to the hypoxemia, and then look at his blood pressure, going from a systolic of 150 to a systolic of way over 200. So that's what happens when you take your when your CPAP gets knocked off, it stops working, or you lose the mask during the course of the night. This is the kind of response you see. And that is very likely going to trigger an event, whether it's AFib or ischemia, we don't know. But what we do know that if you do have CPAP termination, this is a meta-analysis of about 4,000 people, you have increased MACE risks. So there's a MACE, all-cause mortality, stroke, all three of these hazard ratios significantly increased in those people who discontinued CPAP. So, CPAP is not proven to be a panacea, but it's not used as it should be in terms of the full night, and stopping it does have some issues. So what happens if you use CPAP for 4 hours or more per night? And this is an analysis we did with Sharak Javaheri, and it shows control group versus CPAP group. And the main outcome, because of time, I'll focus on the main outcomes. Um, um, Major adverse cerebral cardiovascular events and cerebral and cardiovascular events both were significantly reduced favoring CPAP. So favors CPAP, and you see that there. And what especially came out was stroke, TIA, and not fatal, non-fatal events. So people who use CPAP for more than 4 hours, there's usually a benefit. There's a symptomatic benefit, but there is potentially a cardiovascular event. And remember, this is not intention to treat analyses. This is per protocol analysis, because these are people who use the treatment. They may be selected for other things, and that's why they benefit. We don't know. Here's a paper that just came out in the Lancet from Adam Benjafield and Atul Malhotra. They took a whole bunch of randomized control studies that were done in CPAP versus controls, and they also blended it with non-randomized control observational studies. And they actually found a significant benefit approaching uh, 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 0.35 decreased risk with CPAP therapy. This is a random effects model for non-randomized control studies, and this is taking the non-randomized and adding it to the randomized, and you see there's some evidence of benefit. So CPAP, there's a very strong signal, there's benefit, but it still has to be proven definitively in randomized control trials. Now, what about non CPAP therapies? This is bariatric surgery, the MOSAIC study, metabolic surgery for sleep apnea, incident cardiovascular events. 13,600 adults with moderate to severe sleep apnea and obesity, 970 in the metabolic group, 12,000 in the non-surgical group. Here's non-surgical controls, and this is the cumulative incidence of MACE over about 10 years. And these are people who had bariatric surgery. Bariatric surgery is very good at decreasing your sleep apnea. Let's go back. It's very good at reducing sleep apnea. It turns out that people who had metabolic surgery also had a significantly lower risk of MACE. And here's the details. Health benefits if you have sleep apnea and obesity, 42% lower risk of MACE, 37% lower risk of death, 70% lower risk of heart failure, and the weight loss overall was 24%. So that's great. Bariatric surgery can lower your risk, and it seems to be that in females and in young people less than 52, that's where you get the biggest bang for your buck. So these are the two groups where you get the highest benefit. And actually, it turns out that females may be at greater risk. They have less likely to have sleep apnea, and the sleep apnea is less severe, but they seem to be at greatest risk, and the evidence is very interesting. And certainly, just a whole different discussion. The other thing is young people. They are at higher risk. If you're old and you have bad sleep apnea, you have no diseases by the time you're 70, you probably selected to be resistant to hypoxemia. And so you're young, you're probably potentially at greater risk. But look, not everybody can have metabolic surgery, so we need a non-surgical metabolic treatment, and tirzepatide, incretin-based therapy, is could be that. This is a paper from Malhotra and Lilly a trial looking at changes in apnea-hypopnea index with tirzepatide, a GIP-GLP-1 agonist. And on the left, these two panels show trial one, which were people who were not on CPAP. And on the right, these two are people who were on CPAP but also got tirzepatide. Overall, you can see that the change in AHI was kind of similar, right? Body weight change was also, similar. And so sleep apnea was mitigated by tirzepatide. But look at the blood pressure fall: 7.6 systolic, 2.8 diastolic, 3.7 systolic, and 1.1 diastolic in the OSA with CPAP, tirzepatide part. Now, why would the blood pressure fall in those not on CPAP be 7.6 and those already getting CPAP be only 3.7? They lost the same amount of weight, and the AHI went down about as much. Well, the reason probably is because when you're on CPAP, it drops your blood pressure some, but not a lot. And then if you can further reduce the apnea severity long term with tirzepatide, you get a greater fall in blood pressure if you've never been on CPAP, 7.6. That's just my summary of what my understanding of the data, but you can have different explanations. So to summarize, sleep apnea therapy and CV risk reduction intention to treat analysis. In non-sleepy patients with sleep apnea, CPAP treatment does not lower the risk of cardiovascular events, although depression, anxiety, time away from work decreases, and quality of life increases. Per protocol analysis, some risk reduction observed, especially for cerebrovascular events in people who are CPAP adherent. Weight loss interventions like bariatric surgery and incretin therapies hold promise for attenuation of sleep apnea and for improving cardiovascular outcomes. Biggest benefits in sleepy, hypoxic, young, and CPAP adherent people, and those who have poorly controlled cardiovascular disease, and also we think in women who have been a neglected part of the sleep apnea mosaic. So what I've tried to do then is to talk about central sleep apnea first. That yes, the first trial was not good, but other methods to deliver ASV seem to be okay to treat symptoms. Sleep apnea, high sympathetic activity, high blood pressure, lots of pathophysiology that can give you hypertension, give you heart attacks, give you sudden death. What predicts the risk? Daytime sleepiness is one. Severity of hypoxemia is the other. Young people, another one. And OSA treatment is very much an evolving area. You've got CPAP, you've got bariatric surgery, you've got tirzepatide, the incretin-based therapies. You've also got a whole list of other things I didn't talk about, including the nerve stimulator that you see advertised on TV, positional therapy, other things, but we'll leave that for another time. Thanks very much, then. Happy to take any questions.
Thank you so much, Dr. Summers. That was amazing. You've been leading this field for a long time, and so congratulations in an amazing career and all the work you put towards this important area.
Thanks, Leon.
Yeah, of course. For everyone, please put your questions in the Q&A. Mario Garcia has a question. Glenis, if you want to promote him in case he wants to.
Yeah, should I stop sharing my screen,
Yeah,
Glennis?
if you want to stop
Okay,
sharing.
there you go.
While he's being promoted, maybe I will ask you a question about the pathways. Do you have any pathways set to try to get the biggest bang for your money on, like which patients to screen for even OHA and OSA and which ones you treat at Mayo?
So if for a cardiac patient, I would say people with recurrent atrial fibrillation. So first off, I'll start with people who are obese and sleepy. Those are the ones, regardless, I say you probably have sleep apnea. The AFibs, if they have recurrent AFib, if they're obese, but we just did a just treating all comers at Mayo, a small study, non-randomized, and the ones that were treated with CPAP had a lower recurrence of AFib within a year. But AFib really to do a good study, you need to do an ILR, and the ILR studies have not shown benefit, but the trouble is that these people had established AFib. They've been in AFib for 5 years, and it's hard to fix. It's a bit late because the longer you leave someone AFib, it's harder to snap the atrium out of it. The other issue, of course, is CPAP compliance is an issue. Now, AFib just comes, it's just like one thing can trigger it. So if you got CPAP on, you take it off, you get hypoxemic, hypotonic drive, that can trigger AFib. Even though you're using CPAP, just stopping for one brief period is an issue. That's the problem with the whole set of. We just need treatment that can be sustained through the night, and we'll see, I think, different results.
Thank you very much. Dr. Garcia, if you'd like to ask a question.
Well, thank you very much for such a complete and I think very, very comprehensive and eye-opening presentation that you gave us today. Obviously,
Thanks, Mario.
Leandro mentioned to you that obviously in our environment here in the Bronx, prevalence of OSA is pretty high, and he mentioned the challenges that we have sometimes with testing at the beginning. So I have two specific questions. I mean, you obviously show data very clearly that bariatric surgery and pharmacotherapy to increase weight loss improves sleep apnea. Is the opposite also true? Can we see an effect in weight loss by using CPAP alone in patients with OSA?
That's a great question. So sleep apnea disrupts sleep, and we have randomized, controlled, very solid, robust data showing if you take healthy young people and you sleep deprive them in the hospital for 3 weeks or 2 weeks, versus you bring them back in another time, you let them sleep normally and you let them eat what they want. They eat more calories when they sleep restricted, and those calories go straight to the visceral area, visceral fat. Now, there's data from Japan showing that when you do a randomized trial of CPAP versus control in OSA, you don't find a significant overall weight reduction with the CPAP, but what you find is a significant, consistent decrease in visceral fat deposition. So there's something about sleep disruption that changes the pathway by which the body or the brain decides whether this fat storage should occur subcutaneous, which is the healthy storage, or in ectopic areas like epicardial or visceral. And so there's a very strong link between the sleep disruption and the likelihood of ectopic fat storage. So the short answer to your question, You don't always and not consistent and may not see a weight change, but you have a better chance of seeing a reduction in visceral fat with effective therapy. By the way, as I visited your place about 15 years ago to do grand rounds. It was very nice. I enjoyed the visit. It was great. Met your fellows and impressive place.
Thank you. We'll have to have
Yeah.
you over again.
No, I'm just to make it note. I do know Montefiore. So yeah.
Terrific.
Thank you very much.
I had another question, which I think many of my colleagues will have as well. We see a lot of these patients with not only atrial fibrillation, but significant bradyarrhythmias, and we disregard many of them, but sometimes they are very profound. There are episodes of complete heart block. They are very long pauses. Is there any benefit in any subset of them for pacing?
Okay, another great question. So the thing about the sleep apnea and the heart block and Mobitz 2 and everything and is uh, strangely enough, that is a sign of a healthy conduction system. That is what the body is supposed to do. When you hold your breath, when you stop breathing, when you get hypoxic, you are supposed to manifest the diving reflex, which is high levels of sympathetic drive to peripheral blood vessels and high vagal drive to the heart. And that's meant to keep the brain alive. So that's preserved from our evolution. If you look at diving mammals, they have huge diving reflexes. You take healthy young people, great diving reflexes. They get bradycardic when they stop breathing. I don't know if anyone here has ever done anesthesiology, but when you're putting a kid to sleep, and if you delay that intubation, the heart rate goes dut 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 dut, dut and then dut dut dut. The bradycardia comes on very quickly. So the diving reflex is the reason for that, and it's actually a physiologically normal response. So the treatment of those kind of bradyarrhythmias is to treat the apnea, not to put a pacemaker in, because it's eminently reversible. How do you know it's from the sleep apnea? Well, you got to look on your Holter and see when it's occurring. If it's occurring mainly in the nighttime, then you probably have an apneic driver. But sometimes if it occurs in the daytime, you got to check with the patient they didn't nap, because often they'll nap because they're sleepy, and then they develop the bradyarrhythmia, and you think, oh, it's a daytime Mobitz 2, and let's put a pacemaker in. So be careful with that.
Thank you very much. We have a question here. How was excessive sleepiness determined, as it may be a subjective evaluation?
Another great question. There's two ways to determine sleepiness. You can do what we call an MSLT, mean sleep latency testing in the hospital. It's expensive, it takes time and lots of work. The easier way is the Epworth sleepiness scale. The two don't always correlate, but most of the sleepiness data that I showed you is based on the Epworth sleepiness scale. And there you ask some questions, say, do you ever fall asleep while driving? Do you fall asleep watching TV? Do you fall asleep talking to somebody? Questions of data. And there's a scale goes up to 21, and when you're above 15, it's a problem.
Thank you very much. And I think I'll ask one last question.
Sure.
About sleep variability. If you could comment on the concept of sleep variability and how it can affect. I know it could be a whole lecture on this, but
yes,
if you could touch base on that.
So there's two things. Sleep variability is two things. It's across a population. And yes, sleep duration in a population varies a lot. And we generally say you need 7 to 8 hours, but that's just a generalization. Most people, you need as much sleep. It varies. So people who sleep 4 hours a night, I have a couple of mentors who only slept 4 hours a night, incredibly functional, never sleepy, um, and very successful. Um, and that's because they probably only needed 4 hours of sleep a night. It's a Gaussian distribution of how much sleep you need. And the fact that they only needed 4 hours sleep gave them an extra 4 hours to do something. That's why they were so successful. That's my excuse for not being as successful as they were. So it's really a question of how much sleep an individual needs. Now, how do you know you're getting as much sleep as you need if you're not sleeping in the daytime? And most important, you're not woken by an alarm clock. if your alarm clock wakes you, by definition, you're not getting enough sleep because you cannot make yourself sleep. And so if you have to be woken, then you are, you just didn't get enough sleep. You just so that's the way to determine it. And don't worry if you only sleep 4 or 5 hours a night. If you're successful and you're not obnoxious and people like you, then you're probably getting as much sleep as you should get. But if you sleep in the daytime as you've been woken by alarm clock, then your 4 hours is not good.
Okay, thank you very much. Well, this was a wonderful lecture. We learned a lot, and hopefully we'll have you in person next time.
Oh yeah, no, pleasure, absolutely.
Okay, take
Take
care.
care. Bye bye.
Bye.